So good day, everybody. My name is Dr. Laurent Layani. I'm the consultant bariatric surgeon and laparoscopic surgeon in Sharq Hospital for the last 4 years. I have performed over 10,000 laparoscopic bariatric surgery since 1998. And this afternoon, I'm going to try to give you a little overview of the service we provide in Sharq and some information about this weight loss surgery we call, or bariatric surgery in this hospital and all around the world. I'm going to start to introduce the surgical team. We have 3 other surgeons working with me, a dietitian, which is also a very important part of the team. We have endocrinologist and physicians, cardiologists. In fact, the full range of physicians working with us. We have intensive care, so we actually can deal with all type of patient, from the easy patient to the more complicated cases. Obesity surgery is very popular all around the world, and I'm going to try to give you in this kind of a short interview what is happening at the moment around the world and what we're doing here. Let's start with what in 1998 was mainly the lap band, which was a ring around the stomach, which we performed thousands of patients, and roughly now we hardly do any. The most popular operation we do is the laparoscopic sleeve gastrectomy, like we call Casmeda operation, which is cutting the stomach from a balloon to a banana shape, or the mini gastric bypass, which I'm really fan of the operation, which is one anastomosis gastric bypass, which we also do for patients. We do a lot of revisions, means patient which already has been operated in the past with a band or with some kind of other surgery, or with a sleeve which patient regain weight, and then we change the sleeve to a mini bypass, and sometimes some Roux-en-Y gastric bypass which we have to be changed. So basically we do a lot of different type of surgery. Usually the process is quite very well organized. The patients come because they wish to have a sleeve or gastric bypass. They usually see me or one of my team member. We do a full medical check, checking your medical history, if you have any high blood pressure, if you have diabetes, which is a sugar problem, if you have some sleep apnea, means is when you sleep during the day, you're snoring too much, if you have some other medical issues, if you have some back pain, knee pain, or all the type of problems you can experience. Sometimes patients coming from the infertility clinic because they cannot get pregnant because of the size. So it's really a full interview. We ask you about your past surgical history, if you have any kind of surgery before, which are relevant or not relevant, or in regard to what we're going to offer you. Then usually the patients will say, okay, this is what I want. If patients need to have some cardiac investigations because of the cardiac issue, which is commonly what can happen, we send to the cardiologist, and the cardiologist will make decisions of more investigations, perhaps a cardiac echo. If you're a young patient, obviously you're going to need probably nothing more than a full blood test, which we perform in a hospital. We give you the dietitians is in the same room, in the same office than all of us. So she will give you a little overview of what's going to happen after the surgery, which is usually, regardless of the type of surgery we do, we give the patients a little booklet in English and in Arabic to explain the first 2 weeks, which is a liquid diet stage, and the following 2 weeks, which is the soft diet stage. Dietitians will give you some advice, and all is very informal, quite friendly. It's not really complicated. Everything is quite smooth. There's no issues really. We then decide. We then send you to see the anesthesiologist, which is a very important part of the team. Is the doctor who is going to put you to sleep. He's going to assess all the different investigations, and he's going to give us the green light. He's going to say, well, dear, we are ready. It's up to the patient to decide which day the patient is going to be operated. The patient decide. Usually they come early morning at 7 a.m. when they fast from midnight. We usually perform the operation on the morning, and most of the patient will be discharged the following day. Some patients like to stay an extra day, which is part of the package, so it's no issue if the patient want to go or want to stay. It's not going to cost the patients, in fact, anything more than what was actually decided before the operation. Regardless of the complexity of the patient, if the patient go for a sleeve or mini gastric bypass or even a revision operation, the discharge is often the same. If it is extremely complicated, which is maybe 10 to 15% of the case, maybe the patient will have to stay maybe 2 or 3 days or even more, but this is very rare. Just to come to the specific, a sleeve gastrectomy is basically changing the balloon stomach to a banana stomach. We use a 5 trocar, and we mobilize the stomach, and we cut with some special instruments. The bypass is you don't remove anything. You just create a pouch, like a long banana pouch, and you connect the small bowel. You bypass some small bowel, which will bypass the food, and then so we join the pouch to the small bowel to reconnect the alimentary system. And the Roux gastric bypass is exactly the same. We have also some kind of a new device which coming now is called a clip. It's called a gastric clip or the Bariatric clip, which is also another surgical option, which is replicate the sleeve, the casmeda, without cutting the stomach. It's basically, rather than the ring in the past with a band around, this is a vertical clip, so creating the banana stomach. So as I said, the incisions, what is most common questions is asked is how much I'm going to lose, how much, what is the possible problems and complications, like any type of surgery. I always say to the patients, the operation is performed with 5 little trocar. It takes on average between 45 to 60 minutes, and any kind of surgery has always a small risk, like anything, even if you do an appendix, or if you do a gallbladder, or if you do any other type of laparoscopic operation. But the risk is extremely minimal, but it's like anything else, has to be discussed with the patient. So as I always say, I believe the risk of being so morbidly obese and very big is more risky medically than to have surgery. Usually, particularly for the mini gastric bypass, I always try to, even if the patient, let's say, come for a sleeve gastrectomy, but I have find then if the patient is type 2 diabetic with oral medication and or on insulin, if the patient got some reflux, some kind of hamuda, severe esophageal reflux, if the patient like the sweet too much, we call sweet eater, I really think these patients should have a mini gastric bypass rather than a sleeve gastrectomy, because the result is by far better. So we try to discuss this with the patient for them to understand what is the best option for the patient. In terms of, so this is the surgical part. We usually then discharge the patient. We see the patient after 1 week, after 1 month, after 3 months, after 6 months, or any time if the patient has any kind of issues. We usually give the number of the doctors and myself. Most of my patients do have my phone. They send me some WhatsApp. We have some WhatsApp group. We more than happy to interact, to actually create a connection between patients if they want to talk to each other. Is no issue. One particular group of patients I would like to mention, which is unfortunately, but it's the way it is the pediatric. We do have the right, and we do some pediatric patients. The youngest patients I operated in this hospital, she was 9, and so I'm talking about the range from 9, 10, 11, 12, up to we call the over 18 they become adults. Some countries they have different age limit for when they are adults and not adults. It doesn't really matter. So we do this kind of patients. Obviously, not as common, and my God, it's better, but we do. And in fact, recently I operated 3 members of the one family, 3 sisters and brothers, and we basically also in this situation involved the pediatrician to check all other medical conditions which the patient can have. So this is the surgical arm. We also do have the non-surgical arm, which usually is for the patients which I believe are not surgical, not big enough, let's put a thing this way. And so we have the medical arm with dietary, exercise, and also we do have the balloon, which is a balloon inside the stomach. We offer this. My friend Dr. Nicholas is a gastroenterologist. He's doing this balloon insertion, which is another type of management for this obese, usually smaller type of patient. So I hope this is good information for you. If you do have any question, we are more than welcome to answer your question, myself or my team, or anybody. And thank you very much for your attention.